I've got Coleman Clougherty, is that what you say your last name? Yeah. And you're still Kent State University area? You're in private practice, aren't you, in that area?
Correct, yeah. So I actually work for the Cleveland Clinic in
Cleveland Clinic.
Yep, in Cleveland, and do some teaching and stuff with Doctors Pratt and Rosante at Samuel Merritt.
Right. So we're going to talk to you specifically about the diabetic foot because, of course, diabetes is just it's taking over. When I first started in practice, I mean, we've always had high risk podiatry in terms of diabetes, but I wasn't really involved in the diabetic foot protection team. And since we became involved in that, 50% of my work now has become diabetic foot surgery, and it is increasing. We did a recent audit about post-operative follow-ups with a diabetic foot. And normally an elective patient, so you come in for an MIS bunion, I see you at 2 weeks, I see you maybe at 6 weeks, and I might call you at 6 months and it'll be fine, everything's okay.
Right.
With a diabetic, the average was around 26 visits post-op, with one patient having over 250 visits, which is just unbelievable from a time point of view in the NHS.
Yeah.
It pushed my new patient. Now you're going to think this is mad coming from the USA, but if you came to me as a new patient referral, I wouldn't be able to see you for a year.
Wow.
Which is amazing.
Wow.
It's just ridiculous.
Yeah.
But that's just the way it's gone. But in the UK, we've got a prevalence of around 4.4 million people, I think, have got diabetes, with about another 1.2 million who are yet undiagnosed. And of course, we know that the complications of diabetes can start before you even realize you're diabetic. And it's one of these hidden diseases that people, they don't understand. They don't get it. It's always just a little bit of sugar. I'm only just mildly diabetic, that kind of mindset.
I'm a little sweet.
Yeah. What's it like in the USA?
It is very similar. And I think it's, rampant too. Obviously we have a pretty large percentage of diabetics. I know, our population is bigger in the States, but when I was doing my presentation, I had to pull some of those numbers, and it was astounding. Almost double the number of diabetics percentage wise in the United States versus the UK. And although the hemoglobin A1Cs seem to be very similar, the uninsured in America have over 1 percentage point larger hemoglobin A1C for our uninsured. So, and that was 8.5, 8.6, something like that. It is a really bad problem, and it's even getting worse. And I think the accessibility isn't the issue either, which is kind of the sad part. If someone calls me with a diabetic, problem, whether it's Charcot or, a collapsing arch, whatever, we can usually get them in within the week, if not within the next couple of days. And it still is, it's one of those diseases, like you said, it goes silent for so long and so much is damaged, cardiovascular, renal disease, things that, aren't showing up yet. And all of a sudden they come in with a Charcot foot and, a little bit of diabetes, a little bit of, sugar problems. And there's obviously a lot behind the curtain.
And of course, obesity kind of started in the USA. That's where we always used to go to America on holiday and you go, crikey, me, look at the size of them, but we've quickly caught up in the UK now. We've quickly caught up in the UK.
Welcome.
So is that sort of driving this surge in type 2 diabetes?
I think so. I do think that education, I think, food is getting worse and education is getting worse as well. I mean, medical education, not, I'm not bashing the schools. But I think when I have my conversation with my surgical patients pre-operatively, their level of understanding of their own disease is nil. I think a lot of, I ask them, if I put a bowl of sugar and a loaf of bread in front of you, what's the difference to you? And then what does your body know as the difference? And it's really nothing. They break down both into sugars and, they're flabbergasted to know that stuff. And I think understanding the disease is half the battle. Just like, when people have cancer, they understand everything and they get the treatments for it and stuff. I actually once, one of our infectious disease doctors in residency, I was rotating with him and he said that he would rather have HIV than diabetes because at least HIV you can control with medication.
Which is kind of
sickening.
You wouldn't have said that in the 80s.
Right,
But you're absolutely right. Yeah. It's something that's treatable. It's not going to give you the same complications. You can have a normal life. But diabetes causes so much comorbidity. And people losing the limb, they don't understand that if you lose a limb through diabetes, the 5-year outcome is worse than a lot of cancers.
Correct. And
there was once actually the thing came on the news on BBC News, and it was talking about a pop-up shop that came up in London. And in this pop-up shop was footwear. And people would go into the shop and they say, oh, I like that shoe and I like the other one. And say, yeah, I'll try that one on. So they give them the one shoe. Can I try the other one on? We don't have the other one. What do you mean you don't have the other one? These are the shoes that the diabetics cannot wear because they've lost a limb. So it was kind of a messaging that was quite powerful because it made people really think about limb loss. And I suppose the problem you've got, because people think, well, you'll see an athlete who can do the Paralympics and run, just put a false leg on, they function normally. They don't get the fact that your cardiovascular system is so poor that you can't cope with the demand of only having one leg.
Right.
And once you've lost one, you've got neuropathy on the other side, chances are you're going to lose the other, right?
The other one, yeah. I forget, I think it's within 3 years, 50% maybe lose the other limb, which is astounding, number. And what's frustrating on our side is, we tell these people, they, sit in our office and they cry and, I can't believe this has happened to me. And then they, either change their life around and you never see them again until years down the road, or it's the same story a year later.
See, I used to struggle when I would see a patient in the diabetic clinic. They get an ulcer, and you say to them, you know what? You're only going to be able to treat this ulcer if you get the weight off it. So we'll put you into a cast, for 6-8 weeks, total contact cast, get your weight off it. And I was kind of frustrated by the fact that patient compliance was so poor. And I've thought about this and analysed this, but if you came to me as a patient and said, you know what, I need an operation on my foot, I would say to you, there are 3 phases of this operation. It's going to take you 6 to 10 weeks to get over the operation. Take that out of your life, get over it, get back to normal. You're back to normal. With a diabetic, we're saying, well, I'm going to put you into cast for 6 to 8 weeks. Then we're going to get you healed. Then we're going to get you back to normal. And I can guarantee you within 6 months, you'll be back with another problem. And we're going to do the same again, and the same again, and the same again. Now, bearing in mind, these people can't feel anything because they've got the neuropathy. They could stand on a nail and not feel it's in the foot. You can kind of understand why they go, you know what? Stuff it. I'm getting on with my life.
Yeah. That's actually a really good point. I never thought of it that way.
Yeah.
And that brings up another point too of how long people will go with these ulcers, months on end, years on end sometimes. And the frustration of like, this is just going to happen again, or this is the 3rd time it's happened. Whatever, put on whatever graft or, put me in a cast, doesn't matter to me. And I think it is daunting for the patient to have to do that every week. And they're, it's not like I'll see you in 6 months when you have an ulcer. It's a part-time job of going once a week to get it debrided and get casted. And, I think it's a lot for patients.
So in the UK, we have the National Health Service, which does get quite a bashing. People talk about it being chronically underfunded. It's not really chronically underfunded. It's just poorly managed. It's a typical, national institution that is just full of management and it just doesn't really work. And there's a whole debate in a minute because we've got elections coming up, and everyone seems to be afraid to tackle it. But I must say, from a diabetic point of view, I think we give pretty good service to diabetic patients. So what would typically happen is that we would have a community podiatry service that would provide general high-risk foot care. Now, they used to provide foot care per se to people who had foot problems who are non-diabetic. But because of the severity of the population now needing care, they've moved more into high risk. So all of the general foot care has been moved out into private practice. So from our point of view, we get very good care. Now in America, I went to a conference in Washington on the diabetic foot. And what was really interesting about the American healthcare system is what they were saying was that insurance companies didn't want to pay for conservative care. They would pay for you to have an operation. They would pay for you to have your leg removed, but they wouldn't pay for the conservative care. So does that mean you get worse outcomes, do you think? Because you operate on so many more patients than we do. Is that because of the poor care that's been primarily?
I heard a speech once or a lecture, and they said that the difference between the U.S. healthcare and other places is we define it as sick care and not healthcare.
Yeah.
So unfortunately, especially in the private practice world where, insurance companies are your bread and butter, they don't cover a lot of the needs, the preventative stuff for diabetics, inserts, shoes, braces, all that stuff. And if they do cover it, it's after a huge fight by the physician's office, or, sometimes the patient has to get involved. And if we're not treating those preventatively, they inevitably will, get an ulceration and stuff.
Yeah.
And it's almost like they're, until there is an amputation or some kind of, like Charcot deformity, they don't really care about that. And then once that happens, once their clock starts, as I like to say, their 5-year, 50% mortality. Once they get that first amputation, it's like, okay, now we can, treat these patients and give them the preventative stuff. But by that time, the disease is so progressed, and a lot of times it's too late to turn stuff around.
Yeah. Okay.
Yeah.
What was interesting at the conference is they were talking about possibility of conservative care being put into a what's the big pharmacy called in the USA? It's on every street corner.
Walgreens or CVS?
Yeah, Walgreens,
Okay.
or something like that. They were talking about putting a centre into Walgreens that would provide conservative care for diabetics. Now, what was really interesting about this is it set off this debate of almost panic. That the surgeons were thinking, well, hang on a minute. If we have all these people in a Walgreens that's within 5 miles of everybody's practice, suddenly patients will dry up. We won't have anybody to operate on.
Yeah.
Did that ever happen in the USA?
No,
I
think no, it did not. And I think the rapid growth of diabetics won't change a thing.
It won't change a thing.
Yeah, and I think and I don't mean any disrespect to diabetics. There's a lot of things that go into play. If they have uncontrolled diabetes, obviously they're non-compliant with their medications, and their doctor's visits and all that stuff. And obviously that goes right into their, taking care of their wounds and their ulcerations. It's all non-compliance. Like it doesn't, it's not like they're just not taking care of their feet or their legs. They're, globally affected.
Okay. So when a diabetic gets numbness in the foot, they can't feel the foot. Okay. So if you're walking about on a foot that you can't feel, then you can get injury to that foot, fractures, and then you can set off inflammation, and that can kickstart the Charcot foot. Mm-hmm. So I think that was first described for syphilis, because syphilis was the disease that caused numbness and neuropathy. Yeah. So it doesn't have to be diabetic related, but of course now it's more diabetes that causes a neuropathy. So you get the Charcot foot. So the foot becomes very hot and inflamed, can almost look like an infection. And then it starts to crumble and fracture, and the inflammation washes all the bone minerals out. So you get osteopenia, osteoporosis, and the foot collapses in on itself and you start to develop ulceration. So the bottom of the foot can become rocker bottom rather than having an arch. So what do we do about it? What's your treatment of a Charcot comes into your office? What's your go-to?
I think with a diabetic or anybody with neuropathy, a hot or red or swollen or a combination of the above is always a Charcot until proven otherwise. And I think that's a big misstep across a lot of physician offices. It's mistaken, like you said, an infection or maybe gout. And by the time the antibiotics don't work, and the foot collapses. So it is a immediate non-weight bearing. We put them into either a knee walker or crutches, depending on their athletic status, and straight into a total contact cast. Obviously, we just talked about non-compliance. Yeah. They're going to walk on it on accident or a little bit on purpose. So putting them in a total contact cast. And then I usually do every 3 weeks, 2 to 3 weeks, x-rays to monitor, make sure that bone isn't collapsing anymore. And then eventually into a crow once we have nice consolidation and the patient's inflammation has died down.
Okay. So, You seem to operate on a lot of Charcot feet. Now, in my practice, when I first started on the foot protection team, I thought I was going to be overwhelmed by Charcot, and I'm not. And I kind of thought to myself, well, where are they all going? So I spoke to my orthopedic colleagues. Are you seeing many Charcots? Well, no. So it must be that we're catching them early and treating them early rather than them going to a surgical procedure. So I probably only operate on maybe 5, 6 a year, but you're kind of doing 2 a week.
Yeah.
That's a big difference in numbers.
Right.
Is that because your threshold for surgery is so much lower, or?
I don't think so. So I kind of did a self-reflection a couple of years ago about why are we seeing all these patients? Obviously, I'm somewhat of a referral source for non-surgeons or minimal surgical people, or people who don't want to deal with the uncontrolled diabetic that now has a collapsing foot. I do think that a lot of the diabetics, by the time they get to my office, they are, really far gone, and turning around and putting them in a crow isn't going to help much. And I think that's very unfortunate. Like I love to tell patients, I just saw one right before I came here that is now a year after I caught it, day one, or week one. And he has no surgery. He's still in his crow and doing fantastic. I love to tell patients that, but unfortunately, with how far gone a lot of these diabetics get before they're even evaluated for a Charcot, they're usually either pressure-induced ulcer or pre-ulcerative, and they're going into the OR or at least a big workup.
So are the patients you tend to operate have gone into the kind of quiescent phase of Charcot, but have got deformity with ulceration, rather than acute Charcot that you're intervening early? Because we used to talk about when we did Charcot that you didn't want to really operate on the acute phase, but that's kind of changed a little bit. People are a little bit more easy to pull the trigger in terms of that. Perhaps, I don't know, with using frames and other manipulations, you can manipulate the foot into a new position without cutting into the bone and then putting a frame on it to hold it.
Right.
What word do you see?
So my thoughts on that have changed over the past 10 years. I think the every 3 weeks, every 2 to 3 week x-rays really dictate what I'm going to do. So when I have a patient with conservative care Charcot on the clinic, I never know what I'm going to do until they walk in and get that first x-ray, because it could be a thumbs up day, and we continue with what we're doing, even in the acute phase, or this is starting to collapse and everything is breaking, we need to immobilize you because what we're doing is not working. And those are the patients that in the acute phase are more aggressive surgical actions.
And when you say immobilize them, you mean putting a frame
in
on
a frame.
In a frame.
Yeah, sorry.
So you're not making incisions on the foot.
Correct. Yeah. So we're just kind of doing some manual manipulation in the operating room, maybe try to, push bones to where they should be, pin them in place, and then a stabilizing, usually weight-bearing load, offload frame to allow them to, hopefully non-weight bear, but we know that they're most likely going to, so it's usually a pretty stout frame. Okay. And in the acute phase, I think those do really well with not allowing the osseous progression. They still go through all the inflammatory and erythematous phases. So it usually does come with some pin tract infections because that's swelling back and forth. But it's also better than having an enormous gaping wound on the bottom after they collapse in the midfoot.
Okay. So when you're putting a frame on, I mean, in the UK, it seems to be quite a specialist area. I mean, in our orthopedic department, we have one orthopedic surgeon that seems to do frames usually for trauma, so it's post-tibial fractures and things like that. And so it seems a little bit daunting to put a frame on. How steep is the learning curve for a frame, and how many do you need to do to become competent at it?
That's a great question. I think the learning, it's a very daunting. Everything about it seems larger than life. There's 15 trays that come into the operating room. Everything looks dangerous. There's pins and wires that are all, so I think a lot of physicians don't like to jump into it because it is, they'd rather give that to somebody else's problem kind of thing. I think, after doing 15 cases or so, I think you should probably feel pretty comfortable with it. The first 10 are probably going to be pretty difficult, trying to get a rhythm of putting them on. But I did that course this morning on it, and I think, what I said to the group was having a systematic way and having all of your instruments, your utensils already, laid out makes everything kind of go a lot quicker. And I think that's one of the problems that surgeons have is this is going to take forever, and I think that turns a lot of people off. But
yeah,
I think after about 10 to 15, people usually start to get real comfortable with the placement of the wires. It's all running through your head, all your safe zones, and eventually you get the hang of it, so to speak.
Yeah. I suppose it's a little bit of a catch-22 for us because I've already said that we're not seeing enough Charcot to do it all. We don't get the 10 or 15 to be good at it, so you're kind of caught in this this trap of not being able to be good enough at doing it. Although, for me, I'm kind of getting over the hill a little bit. But my colleague Tommy Chan, he's young and dynamic, and he's keen to get into that. So perhaps it's something we really need to be looking for. Perhaps education on, when to refer Charcot in. I suppose people not realizing that something can be done early on. It can be a bit of an issue as well.
Yeah, and I've had a handful of patients that have come to me and said that everyone they talked to said amputation, and it's although that's the case for some of the patients, there are things that aren't, an automatic amputation, and that can be, salvaged. Like we said in the very beginning of this, losing their leg is a huge shock to their entire system.
Yeah.
So, and patients have a huge mental tie to their body. And I think it was Ruckus in 2017 did that article about how diabetics in the United States would rather die than lose a limb.
Yeah.
And I think that was really telling to like how these patients, they're not just, a patient that has a disease, like they have, these emotional ties to things. Yeah. And most of those patients have seen a family member, a loved one, go through the, they got an amputation. 3 years later, they were no longer here.
Yeah.
And I think that, that is in the back of a lot of people's heads to prevent them from, wanting an amputation. So, it's kind of our job to step in and say, that is your only choice or not.
I mean, it's interesting. I've had a few patients who would rather have, I operated on one patient yesterday and we did a triple arthrodesis for a varus hind foot. So, essentially what this guy got was an ulcer over the base of the fifth metatarsal, got infected to bone. We ended up having to remove the base of the fifth metatarsal and pack it with antibiotics. He ended up getting an inverted foot. We've had him in a total contact cast for a year and struggling to get it healed up and down. And so there was a conversation, well, if I cannot get this healed in a total contact cast, what's the point in straightening it? If it's not going to heal non-weight bearing? He'd been very compliant. To top it off, he'd had vascular issues, so he'd had a bypass graft for that. But we did get it to heal. And but we almost had to talk him into then trying to salvage the foot,
right? Because
he kind of gone down the line. Well, I've had enough of this. I'll have a year of being in a cast, and how long do I need to go through the next phase? And my take on it was, well, we'll probably know within 12 weeks whether this is going to work or fail. Something will go wrong in that first 12 weeks and we'll know. So you kind of know worse off because knowing that if he lost one leg, he might lead to the other. So, so you do get that kind of thing. But I fixed that internally. So the ulcer was healed, I fixed it internally. And most of the ones that I've dealt with have had quite severe bony deformity. So the foot's collapsed.
Sure.
What was always a bit worrying to me initially was how aggressive you have to be sometimes to remove the bone. And it kind of a bit flies in the face of people who do it MIS, because I know how aggressive I've been to remove bone to try and move the foot back into a good position. I'm kind of thinking, well, how do they do it? How do they do it at MIS then? It's just another annoying thing about MIS, really.
Yeah.
But then I've gone down the route of putting beams in, so putting a beam all the way down. So if you think of a piece of concrete and you put an iron rod in it, it's kind of working the same way. The beam is down the metatarsal to try and hold it. And you would think with the size of them, these will never break. You do get breakages in metalwork failure. When do you beam it and go internally, and when do you go for a frame?
Okay.
What's
That's a great question. I think I really have two types of patients for Charcot. The first type will be our no frame patient, let's say. So those are the patients that have a very stable Charcot. They went through the process. They just have a rocker bottom foot in a crow, in pain, whatever the case may be, and need it fixed, ulcer free. Those patients I'll go straight to beaming. So I'll do the joint prep just like I normally would. I'll do I compare it to rebarring just like you did, ironically, to patients and, throw them, make that triangle from the medial, lateral, and subtalar joint for the stabilization for it. The other group is the very unstable Charcot, meaning that they either have a wound, they're in the acute phase, or just a floppy foot, so to speak. And those patients, I will stage. So I'll put them into an external fixator, maybe joint prep at that time. Just depends on how swollen, how acute they are. Cut out the ulcer, do a osteotomy or a closing wedge to reestablish that arch, and I'll throw a frame on and keep that on for 3 months.
Okay.
At the end of that 3 months and a confirmed either X-ray or CT of fusions, I'll pull all the pins, and then percutaneously, this is my MIS that I do. Percutaneously, I'll rebar it again. So that's when I'll put beams in.
Yeah.
And that's, I think that's just for them to feel good, for me to feel like, even if it's not done healing after that 3 months, because that frame's about to fall off anyway, or they're going to rip it off, from that cage rage. I think they're like ready to, have that internal fixation at that point.
Okay.
Yeah.
So in terms of, most of the Charcots that I've dealt with have been midfoot. So the arch has collapsed down rather than being hindfoot where the ankle's gone. So I've kind of wedged the midfoot and put a beam across that. So if it was purely midfoot, would you fuse a subtalar joint to get that triangle? Or so I've only done it where I've done the midfoot. And interestingly enough, if it's been like a navicular cuneiform collapse or a first metatarsal cuneiform collapse, and even though I've driven the beam across the talar navicular joint, I haven't always prepped the talar navicular joint. My thought process is, well, it's not collapsed out, it's a straight joint. So if the beam's going across it and the other's fused, that's going to be stable.
Yep.
Would you think like that, or do you prep it?
I do. I also am if the midfoot Charcot, I kind of am in the biomechanics world of, I think the subtalar joint motion is going to be detrimental to us in the long term. I think Patrick Burns out of UPMC, I think he wrote an article about the subtalar joint fusions with the midfoot and then the isolated midfoot, and the subtalar joints doing long term a little bit better. I think their range of motion is going to be shot regardless. So I'm a big proponent of doing the subtalar joint in combination with the midfoot. And especially, if there is an ankle joint involved in the Charcot, which I see a lot of those, that is one, 10 out of 10. It's also getting a subtalar joint fusion too, because that motion and stuff.
So you're not doing anything with the ankle joint as such.
For an ankle, yeah.
So if you thought there was change in the ankle joint, you would do the subtalar, but not the ankle.
And the ankle.
You do that,
yeah.
Right.
And usually those are, nails or external fixators, whatever. But to have a very solid rear foot, and then usually osteotomize that midfoot to allow for some motion.
Okay. So are you prepping the subtalar joint?
Yes.
Okay.
So I did a lot. I was a non-subtalar joint prepper for a while.
Okay.
And I noticed that sometimes they fused great, not prepping it. But I did notice that when they did fail, they were almost always right at that subtalar joint location. That little area just like kind of cracked off, and having to take those out were, always a pain. So even if the ankle joint fused, that subtalar joint still range of motion. So I went to prepping the subtalar joint a few years ago,
Mm-hmm.
And I haven't changed since then.
Okay. So how much of your practice is diabetic foot and how much is just elective problems?
I do probably 90% of my practice now is diabetic foot.
90%?
90, yeah. I occasionally get the trauma which I guess isn't elective either, but a couple, elective things here and there. But they've, working at the clinic, they've kind of put me into a Charcot lane or a diabetic foot lane. And we've been running there for quite a while. So got a lot of uncontrolled diabetics that were,
And do you enjoy that? Because when we do the vascular ward round, and you go onto the vascular ward and you're like, my goodness me, it's so depressing. It's just, and I say to the vascular surgeons, you guys must just be depressed. I mean, I do a nice, easy bunion. Patient comes in, thank you very much. You've been brilliant. You get great reviews. And Charcot, I mean, you're just married to them, aren't you?
Yep.
They just never go away. Diabetics, you're married to them. And the vascular cases, it's just, I don't think I could cope with doing 90% of my work.
Yeah.
So do you not feel like you're becoming de-skilled in the elective work?
I think, I still am very involved in the residency.
Right.
So I run most of the cadaver labs for them, and I go straight into doing electives as soon as I can to kind of get my break out of the diabetic foot. I really enjoy it, although they are a very tough, population to deal with. You're not only with the patients, but their health, their social and economics are not all the times great. Family dynamics are not always great. I don't think I can say I leave my clinic happy every day or joyous. But the reward for me is high. So I do really enjoy doing it. But it is a challenge. And that, and add on to that, knowing that 90% of my cases most likely will be compromised due to their diabetes.
So in the UK, we have an MDT, and we work off the NICE guidelines 19, which essentially says on the MDT there should be a vascular surgeon, there should be a podiatric or orthopedic surgeon or a combination of both. Ideally should be an endocrinologist, and then there's the add-ons microbiologist, orthotist, community podiatrist who does the routine care. And there's certain guidelines that we try and meet. We're actually not fully meeting NG19 in our NHS trust just because we don't have enough. We should have a weekly MDT where we only have it bi-weekly. And it's easy in the NHS really because all of those people work for that national institution. How does it work in the USA? Do you do the same thing? How does it work in private?
I think it's very hospital and practice dependent. For me, I'm very blessed where almost 95% of my patients probably I am taking care of this problem, and all of the people that are also taking care of them all work at that hospital too. And we have group epic chats and all that stuff to discuss everything.
And do you see patients together? So you're all in a room, you're not in the room together?
So that's kind of like a practice that had gone away, unfortunately. I think, when we do have a very, very, troubled patient or someone who is, at the fork in the road of limb salvage versus amputation, I make it a point to bring as many people into the room as possible, not to overwhelm them, but just so they know that we are all, talking about what's best for them. Because, it's a big emotional roller coaster when the patient comes in and they're told they're probably going to get an amputation or they have to have this huge surgery or whatnot. So I think it has become something that we do for the outliers, but not for the norm.
I mean, I suppose that's where it works well for us because we have the MDT where we're actually in the room together. So I work with a vascular surgeon. So we've got that real kind of toe and flow model where they can say, we're happy with your circulation, get on and do what you want to do. Or, we're not quite happy with it. We're going to do some further investigations and maybe do an angioplasty to open the vessels up. And then we'll hit them straight away as soon as possible afterwards with the surgery we want to do. I suppose when you're not quite in the same room, it's a little bit more disjointed than that.
Yes, correct. Yeah. But, and the idea is that happens with every patient. And, the communication amongst everybody is really great. I think when, people in the outside world come into the hospital, for, let's say some vascular surgeon who's private practice and not part of the hospital setting, not that it's a bad thing, but it is more difficult because they're, not there. We can't all meet together at 7:30 in the morning to talk to the patient or whatnot. But it's something that is really important, I think, for the patient's sake.
Yeah.
So we try, to emulate that.
Yeah. Well, certainly one thing I can say for sure is that diabetes ain't going away, and we're going to be busy for the rest of our careers. So thanks very much, Coleman. It's been a fascinating insight.
Yeah.
And thanks for giving up your time and your expertise and coming over to help our trainees and even our consultants with framing. Enjoy the rest of your conference.
Thank you so much for having me. Appreciate it, Tony.
Cheers.
Cheers.